Good evening, everyone. Welcome to the Critical Care Lounge. I'm here with the always talented and handsome Adam Green. What's up, my man?
Not much. How you doing, Handy?
I'm
We're
doing great.
we made it through the holidays, right?
We made it. We made it. Skimmed the trees a little bit. All the crazy stuff that happens around the holidays. But how was your holiday and how was your New Year's?
It was good. It was good. I worked over New Year's, but Christmas was great. Santa Claus came, all the gifts were delivered, everything went as planned. How about
Ev-
you?
Everything was good. You know what I find this time of year is people always say, "Hey, did your kids get what they want?" It's like, screw the kids. My question is, did you get what you wanted? Did you get what you wanted this year?
I don't want much. Yeah, I did. I had a nice time. I went for a cold 2-degree run in the Poconos. That was a nice time.
Uh huh.
Yeah,
Are
yeah.
you the type
No,
of
everything was
person?
good.
Are you the type of person where your wife asks you what you want, you're like, I don't know, and then on Christmas Day you open up, it's like, oh, I should have gotten something better. Are you that type of person?
Oh, no, no, no. I bought myself a bike, and I said, Heather, you don't have to worry about me. I've already got my gift.
Oh, what
And
a
she
great
said, good.
guy.
I bought my gift too. So no, we try to do the no gift thing.
Yeah,
Yeah, it's just better.
good
But
man, good.
how about you? Were you up in the Poconos too, or where
I
were
was
you?
not. No, we laid low. We stayed here locally and had a good time. Did a traditional Malamak Christmas. It was a lot of fun.
That's great.
Cool.
That's great. Well, so before we get started, I wanted to tell you a story, and I know you
Oh,
love it when I do this because it never works out. Um,
that's not
we
true.
all remember the "What's your favorite condiments" part episode. Um, I really liked our last episode. I thought it went really well, and I one of the fellows, I'm not going to name her, said, "Hey, do you have any good primer on VV ECMO?" And I said, "You should listen." She listened to the whole thing, and her comment was, "Where can I get those sweet sweatshirts?" It
Ah,
wasn't like great episode, love the content. It was like I need one of those sweatshirts,
tell you what,
and
man,
I
it's all
thought,
about branding and marketing. That's all that
that's,
matters these days.
screw the content. Um,
Exactly.
all right, so what are we talking about today? Let's get into it.
Today, this is an episode I've been really excited about because not only is this one that generates so much discussion in critical care, it's something that we do every single day, and that's vascular access. What types of access we need early, um, venous, osseous, we're going to talk about it all, but we have a great guest on today, one of our colleagues and rising superstar in the mechanical circulatory world. Let me introduce her, Dr. Lindsay Glaspie. Welcome to the show.
Thanks for having me.
It's good to
Very
have you.
excited to be here.
How were your holidays?
Lovely. I worked at Cooper Christmas, but had a nice Happy New Year.
Before we get into the meat of the show, I got to tell you that I personally am one of those people that I'll try not to work the holiday. But if I do work the holiday, I think it's the best. The nurses bring in food. You get these vouchers for meals. I put on more weight working than I do at home. So that's just my personal slant
Yeah,
on
lots
things. But
lots of cookies and the finest chocolate CVS had to offer. That was my that was my snacks over Christmas.
well done. All right, well, let's get into it. Let's talk about vascular access. Adam, do you want to kick us off?
Yeah, so I was going to say this episode I think is going to be a little different as opposed to us asking the guests all the questions. I think it's we all have such strong opinions that it's just going to be kind of a free for all. So I thought what we should do to start is just say let's get all on the same page for different terminologies. So I know I may use the term shyly, and that may mean something different to someone else, and it not necessarily synonymous with HD catheter. So I thought let's just level the playing field. Let's just talk about all the types of access that we're going to go through, and hopefully we'll hit on each key one as we go. So I don't know if you want me to do it. If you want to kind of go through them, what's your thought process when you hear access? Like what comes to mind?
Well, Lindsay, why don't you go first? You're our guest.
Sure. So I think about it in terms of, classic peripheral IV access to the central access to specialized central access, which would include things like dialysis lines, or even, as you mentioned, things like, ECMO cannulas, in the largest sense. And then including other access points, including things like intra-osseous access, which is a critical and life-saving intervention. I think it may be underutilized in certain settings, and certainly something that quite a few of us are pretty passionate about as well.
Yeah.
Yep, I think that's great. Yeah, I mean, I think we have our standard peripheral IVs, which most people, what we can say is 14 to 20 gauge, but probably reality is more like 16, 18, 20, 22. And then I know that there are some kind of getting into the world of cellular technique is the smaller but larger bore, shorter but larger bore rapid infuser catheters, followed by midline, and then it moves all the way into the central line category. And when we use the term central, I think sometimes it's confusing. It's not centrally located, it's centrally ending, right? So a PICC line, for example, is a central line in that it ends somewhere in the SBC, RA, PA, IVC region. That would be central. So whether it's subclavian, IJ, femoral, or peripherally inserted. And then I like the term, go ahead.
No, I was just going to finish your thought, and then I'll add in some stuff.
I think it's important to say, like, we use the term cordis sometimes, or you'll hear people use the word introducer. Those are synonymous. They're shorter, larger bore, and we'll get into them, and we'll get into the indications and how to think about which one you pick. But those are shorter, specialized catheters, either for rapid transfusion or PA catheters or TVP placement, right? And then finally, of course, we talked about the HD lines, which the two brand names I know people talk about is Shiley, and then the one I can never say but starts with an M, Merhoker, which is the ones that like have the weird little, whatever they're called.
Curves down.
Yeah, those guys. And then we're not going to mention trialysis because I have strong feelings in that none of them are nice.
We don't want to trigger Adam.
We're not even going to get into the trialysis world. That's
it's too early for that.
Yeah. Maybe later in the show when we get
in the show we'll stir it up.
Yeah. I mean, a couple things. The first is, it is convention to say things like cordis or Shiley, and I think you can debate whether or not that's right or wrong. But the most important thing is you communicate to your team, if you're going to say that, what French you need. Are you talking about, like, I hear people saying we need a cordis to do the transvenous pacer. It's like, well, no, that's not the same thing. Be very specific about what you're asking for. And if you don't exactly know what it is, then describe it in terms. Like, I need the smaller introducer to do a transvenous, because every hospital is going to have different brand names for what they have. Last thing you want is in the middle of a resuscitation, someone bring you the brand name, because it's likely the tech who went to the supply room to bring that to you. The second thing is, when you started this off, you say, tell me about vascular catheters. It is very important for me to know what we're trying to do. And we'll get into that a little bit more. But if I'm resuscitating a patient who's having hemorrhagic shock, I'm going to be asking for a very different catheter than if I have somebody who is septic and I need lots of medications to give. And I'll just leave it there. And cardiac arrest is the same thing too. What are we trying to do in the cardiac arrest? What is going to get us the fastest access and the best safety profile? So I just want to put those thoughts out there, and we'll keep moving.
That's great. I have a question. And I think it's probably really important one, Haney, and you can jump in on this, or maybe Lindsay, whoever wants it, is we use the term what gauge and French all the time. Which one's bigger? Which one's what's the deal there? Why don't we just use one metric?
Yeah, so I can take that one. So, when we think about identifying catheter size, we're talking about, we want to get a sense of what the diameter of the lumen is. And there's two kind of major conventions that are used. So a gauge is typically reserved for needles and for small bore catheters, versus the French, which is typically in convention reserved for identifying the diameter of a larger bore or more central access point. And why does it matter? Well, we need to know sort of what size we're asking for. So specifically for French, we know that the lumen diameter is directly proportional to the actual catheter size. So as you go up in French size, you're going to go up in catheter size. And conveniently, you can actually even know the exact size of a French catheter because it is essentially 3 times the diameter. So you can know, for example, a 9 French cordis is 3 millimeters in diameter. So you can get a sense of exactly what the size of the catheter is, versus a gauge, which is it's defined inversely. So, a 22 gauge catheter is extremely small, whereas a 16 gauge catheter is very large. So it's really helpful to know those terms, because specifically in the moment when you're trying to escalate the resuscitation for a patient, you need to be able to very quickly be familiar with those terms to communicate with your team and with your techs, your nurses, who are going to be hopefully helping you with your equipment and interventions. It's very helpful to kind of know those terms.
Yeah, I don't know where this gauge and French thing. It's probably a quick Google search to figure out where it happened. But my understanding of gauge is more for like industrial and wires, and that's where it comes from. But how it crossed over into medicine, it creates a very, maybe someone that knows in the audience who's watching can let us know. I'm very interested. I'm just too lazy right now to look it up. But to your point, it is very important to know what you're going into, what to ask for. And I guess we'll start talking a little bit about why the gauges are important for the indication, or the Frenches are important. Let me put this graphic up on the screen here, hopefully that you can see. And this illustrates the standard catheters and IV catheters and central catheters that we use. And this that I stole right off the EMT website, but it's a really nice graph that shows right here where you have the rapid infusion catheters, which are the largest bore and also shortest, which gets you the fastest flow rates. This would be something that you'd preferentially use for someone who's, in hemorrhagic shock, where volume is paramount, all the way over to the end where you get to like number 6, which is like your 20 gauge IV, where you're just trying to get some medications in. Of course, if you keep going over the side, it should have like the little tiny pinky IV that comes over when people have dopamine infusing coming to our ICU from some of the outside hospitals. But the point is that that's just a quick reference for everybody as to the landscape of catheters. So, Adam, do you want to add anything in on this graphic or anything else?
Yeah, no, I think that's great. I mean, it's just all about laminar flow, right? So I'm sure you're going to get into it, and we're going to talk about how do you get a set volume into a patient fastest, right? If that's what you're aiming to do. And so it's not just about diameter, but also length of catheter, right? Which is why, if you want to talk strictly about infusing blood fast, something like a 16 gauge IV may be your best choice. And I think that's the point you were making, right, Haney?
Yeah, I think people sometimes get a little too cerebral about it, and they're saying, well, I have somebody who I'm trying to volume resuscitate, and I'm going to give them medications too, so let me try to put a catheter with lots of lumens in. Now, if you need to give volume resuscitation for people, then you need to give someone something that is short, right? The shortest amount, so the least resistance, and also the widest diameter. And we're not going to go into, Poseel's formula and all that stuff. But the point is that that's the catheter that you want when you're infusing massive amounts of volume in people. And then to add to that point, you also want to make sure that everything attached to your catheters there's no like stops in between, like a J loop in between a 14 French catheter to the IV tubing is a potential stop point. So you've gone through all the trouble putting a 14 gauge catheter into somebody, and now you are putting like the J loop in. That's going to cause a significant amount of resistance. I don't think people understand all of that when it comes to that.
Mm-hmm. I think I just saw a tear from Adam that he's not allowed to talk about Pascal's law.
Oh my gosh. I was laughing. I was laughing because that is something, if a guest mentioned, you would have been all over him, and you would have ripped on him the entire hour. But it's okay when Haney does it. That's great. But I want to recognize. I think sometimes it's cute to say the 16 gauge IV is what we need, but let's be serious. These patients are sick. We lose these IVs, they get knocked out, and then you're in trouble. So I recognize the need for secure IV access, and I recognize that a quickly professionally inserted central line or introducer, like there's benefits other than just how much blood I can get into someone, and I think that's sometimes lost. Um,
Fair point. Fair point. Um, let's talk a little bit about, let's stay with hemorrhagic shock for a little bit. You have someone that comes in hemorrhagic shock and they're right there in front of you. Let's say a massive GI bleed, you're resuscitating them. Would you rather have a 8.5 French cordis, and that again, that's a brand name, but 8.5 French catheter, or would you rather have two 18 gauge? I know people say 14 and 16, but sometimes people have poor peripheral access and, you know, the person's a vasculopath. So something like an 18, I think, is reasonable. Lindsay, what would you take in those situations?
So, in that specific situation, when you're really trying to rapidly transfuse blood specifically, if you have the availability of something like a rapid transfuser, having the cordis is essential. And the benefit being that you can now provide warmed, blood, which is what that patient really needs if they're truly being massively transfused. It can't be beat. But in many situations, those two peripheral IVs, they will save you. And you can also, you can use a traditional supported device to be able to provide additional pressure to transfuse 2 units through separate IV points, which is really helpful as well. But if you've got, a Belmont or another brand name, rapid transfuser, and you're trying to do that through peripherals, you're going to run into a lot of trouble.
Yeah, what do you think, Adam?
Yeah, I agree. I mean, I think if we're going to pull up that chart, I don't know if you have it available, but that's probably the chart. So I always remember a cordis can get a liter bolus in about 3 minutes, and that's just under pressure. That's not even with the rapid transfuser. Versus something like I don't know, 16 gauge, I think is something like 4.5 minutes. And so, there's just a huge advantage to having that cordis. There's also, it is central access. And so I'm sure we're going to talk about vasopressors and peripherally and if that's safe or not safe. And it is clearly safe going through the cordis.
Yeah. So this chart, let me just orient everyone to this chart. This is a chart of the relationship of time to infusions, the flow rates, and access by gauge under pressure. Now, this in itself, you'll see lots of varying charts like this on the internet. And someone said, "Oh, I thought you said that the 8.5 French is 3 minutes, but here it says 2 minutes." These are some of the things that they're not standardized across study groups. So you'll find some variations. Not much. I mean, 2 versus 3 minutes. It's getting blood in there very fast or volume in there very fast. But just be aware of that. Again, is a J loop used in between? Are there lots of Ys that are used in between? Are they using a standard sort of manometry type system where you're pumping up a pressure bag, or is it on something like a Belmont? Those are the variables that we can't control for. But the point is that this gets you in the ballpark, this chart. And as you can see, if you look up, a 20 gauge under pressure will give you significantly slower rates than if you go all the way down to an H French introducer sheath. And I think people know this, but we have to be cognizant when you start to get to the triple lumen part of things, because there is this misconception that I'm putting in a central line that equals rapid vascular access. And this happens even in some senior people. And you just have to remind people, it's like, what is the indication for this line that you're putting in? Is it vasopressors? Well, then we don't need to go and dilate a vein up. But if it is for volume, I would my first poke wouldn't be to do a triple lumen. It would be do the introducer. And then we could talk about some hacks later on that you can actually slip a triple lumen into an introducer once you're done with the massive hemorrhage resuscitation, and then have it as a multi-port type of catheter.
Yep, love it. And I see Dr. Bonk's comment about HD catheters, and I don't think he's being a proponent for putting in HD catheters over cortices for rapid transfusion. But if you have that dialysis patient that has a permacath in place and you need quick, good access, then if it's in an emergent situation, I am quick to jump to that HD catheter.
Yeah. I think that there are people who come in very sick and they already have the catheter, and there's almost like this, oh, you can't use a catheter. It's like, this person's dying. You use
Mhm.
whatever you have,
Yep.
and you try not to use it for blood draws and all that stuff. But this is an indication where it is okay. So pop that open. And I'll tell you, uh, in my residency, we one night, it was a busy trauma center. We ran out of all cortices, which we were using on patients. And one of my attendings came over with a dialysis catheter. And he's like, put this
Mhm.
in. I was like, I've never seen. He's like, it's a central line, just put it in. And just to see the blood, and it wasn't even under pressure bag, it was just draining.
Mhm.
To see it just go so quickly, you have an appreciation that this is a major resuscitative catheter. So people should put that in their tool belt if you can't get the 8.5 French, or someone comes in with that. That's a gift to you during resuscitation.
That's great. That's really great.
Yeah.
Do you mind if I switch? I'm going to ask Lindsay a question and switch gears just a little bit. So we've talked about the major advantage of introducers or large IVs, which is just get volume in quickly. And I would
Mhm.
say probably the biggest advantage of, we'll say, a central line, a triple lumen, is that you can give vasopressors. So does that mean to you all patients in shock that need vasopressors must have a triple lumen? What's your approach to when do you place them? Can you use peripheral IVs? What's your thoughts on that?
Yeah, absolutely. I think that it can be commonly thought of that, really vasopressors are reserved only for central access. And if you think about kind of officially, a primary indication for obtaining central access is for caustic medications such as vasopressors. But I would say in two particular settings, peripheral IVs are really critical for vasopressor administration. One is in a temporary circumstance for any patient who is in extremis. So there is really no temporary limit. If you have a patient who has a good IV and they are crashing, you are using that line for as high a dose as you temporarily need to stabilize the patient and then get more secured,
Yeah.
access. But I sometimes will, you'll get resistance from different teammates who are saying, actually we have a policy and you can't go above 10 mics of levofed through a peripheral IV. Well, if the patient is dying in front of you, your number one priority is to achieve a period of stability where then you can change your risk benefit analysis and say, hey, I now have secured access and I can transition this high dose vasopressor over to a central access point. That's kind of one category I think of. The next is really
Mhm.
somebody who just kind of needs this low level, again, I consider it as like a less than 10 micrograms of, norepinephrine. They're needing that over a period of perhaps days in the ICU. And they are, and I would consider even de escalating central access for someone who's requiring lower doses. We certainly know that we can safely administer lower doses of vasoactives through a peripheral IV over a longer period of time. Those are kind of two major groups that I think of as ideal candidates for ultrasound for really peripheral vasoactives. And specifically, if you have an ultrasound guided access point, that has been confirmed by ultrasound. You know the position of that IV. It really just increases the safety for that more longitudinal use of low dose vasoactives. You're sparing that patient the risks of, that central access and the associated infection risks, mechanical complication risks. And so as long as the site is monitored, as long as you have, a good safety profile, kind of, at an institutional level, using peripheral vasopressors, particularly through ultrasound guided access over a longer period of time is becoming much more accepted and much more in line with the standard of care, that I'm seeing.
Yeah, yeah, that was really well
Yeah.
said. I love that. And when you're putting in those IVs, I think it's so important about if it's okay, Handy, I'm gonna
Yeah.
hog the mic a little more. It's so important to think about where you're placing them, how you're placing them. So forearm, upper
Yeah.
arm, great spots. AC, no
Mhm.
way. Any part of the body that's bendy, I'm going to try to avoid. And a really deep vein, even if it's big, I don't really want to go there because I know my catheter may not reach it. So having those longer peripheral IVs is important. But really,
Yeah.
probably the most important thing is how much of my catheter is actually in the vein. So tracing into the vein, I think is just it's for sure a skill, and I think it's significantly harder than any central access placement is to get a really good peripheral IV for vasopressors. I don't know, Andy, do you agree with all that? I'm assuming you do. You're shaking your head.
Oh yeah, 100%. I think in 5 to 10 years we'll have the study that shows us that the risk of a central venous catheter, the acute risk of placement, and the long-term complication with CLABSIs will outweigh the risk or the perceived risk of extravasation. As Lindsay and you said, the real risk is the complications that you get from it. There's nothing that says you can't infuse a vasopressor into a vein. As long as we can agree upon it shouldn't be right here in your pinky. It should be everything above the elbow is where you should be infusing. And there was a nice study that often doesn't get talked about. I don't know why, but in LIJ, Paul Mayo has this. They try to do this central lineless ICU, and they did a study in the Journal of Hospitalists a number of years ago, but showed that not only can you successfully treat your patients with peripheral IVs, but when they get extravasation events, what do? They just take out the IV and they put another peripheral IV somewhere else. So, again, I think that study is just yet to be done. If anyone in the audience wants to do it, I'll be first author. That's fine. But the point being is that I do think that that's where we're going to find ourselves. There's so many people who we bring into the ICU. We know this. Any intensivist knows this, and I know both of you know it. So many people we bring to the ICU who just have some sepsis, got early source control, and they're just a little vasoplegic. They just need like that 5 of levo. And you sometimes look at them, it's like, why is this person in the ICU? Well, they're on vasopressors. So it's like, yeah, but they're getting it run peripherally. We have a good safety profile. We have a good nursing protocol that checks the site every 2 to 4 hours. This person might be able to be managing the floor in a few years once we just have that data. So that's my 3 cents on it.
I love the Paul Mayo plug. That's where I did my residency, so I was probably one of the residents putting in those peripheral IVs for that study. But I love this question here about midlines. I don't know if you see that by Michael. He says it says how long do you all feel comfortable in using vasopressors through a midline? And I think that's fascinating. So I want to be kind of clear with what we're talking about. Number one, I think there is quite a bit of data looking at safety profile of low dose vasopressors through a peripheral IV. That's been shown. Probably the biggest problem with that is length that you can use those IVs, because at some point they go bad, right? You don't have blood return, and you really want blood return to really know that you're in the vein as you're infusing. Because if anyone has seen necrotic skin from extravasation, like, that's no good. And so midline, there is only one that I know of, retrospective study looking at the safety of vasopressors through a midline. Now, for people who don't know, midline is a Seldinger technique, not centrally ending, peripheral IV, right? A little longer than a peripheral IV, shorter than a PICC line. And there's one retrospective study looking at that. And I would love, and it's been I've been trying to design it, but a head-to-head of peripheral IV vasopressors versus midline vasopressors. I think extravasation would be similar. I also think the number of procedures needed per patient would be much less with those midlines because they're so much more reliable.
Yeah, great points. Again, as long as you can have it in the vein and you have good safety, I think the midlines might even be less than IVs and the things I've seen. But it all comes down to protocols and monitoring. That's at the end of the day. I don't want anyone here to think like, oh yeah, I'm going to start using peripheral vasopressors. If you don't have something in place in your hospital where a nurse or physician, but nurses are usually the ones who are doing the patient checks on a regular basis. If you don't have that in place, you probably ought not to be doing it unless it's a dire situation where that person needs vasopressors. Every time I talk about peripheral vasopressors, I feel like that's my disclaimer, but it's actually pretty true. If someone's not monitoring that site, you're asking for a lot of trouble, because it's not that with peripheral IVs and vasopressors, you're not going to get necrosis. It is a thing, and anyone who's seen it knows it actually can happen. But with good monitoring, you can mitigate that risk.
Yep. And there's a bunch of really good protocols when there is extravasation, what to do. And first thing, don't take out that IV. Everyone wants to take it out. First thing, leave the IV, suck out as much as you can from it, and then there's usually phentolamine is what's used. And I will tell you, every single time I call my plastic surgeon to come look at the patient, and they look and they laugh at me, and I was like, I just need you to come and look and make sure we're okay, and I just do it. But yeah, there's good protocols out there that I definitely recommend looking at.
Cool. All right, let's move on now, and let's get into the central line world. So, for whatever reason, you've decided that a central line needs to be placed. The questions I'm going to throw to you all are: what locations do you like? And we can use this for. We can just talk generally about whether it's an 8.5 versus a triple lumen versus a quad. Let's kind of categorize them all together. Let's talk about locations, complications, where you would want to see a central line. There's definitely a lot of myths, and then there's a lot of truths. So let's go through it. Let's start off with the IJ. Lindsay, what's your overall feel? Or let me ask you this. Let me change that question. If you have a patient that you're rolling up on, they're septic, and you have to start them on vasopressors, where would be the first site that you would like to place your line, all things given created equal?
Would love to have a subclavian line. If it's a triple lumen, if it's in the setting of that picture that you've mentioned, from a long-term line maintenance perspective, would love to have a subclavian line in place, particularly in considering the infection risk long term. Realistically, in a patient who needs it, more emergently, and depending on the operator's comfort, the go-to line may be a right IJ. And in certain places and certain populations, I think that is a great place to go. From a safety and from a mechanical complication perspective, and then long-term infection risk, it's not an unreasonable place to be. But if I could do a subclavian, based on anatomy and comfort with either ultrasound, ideally with ultrasound, that would be preferred.
And I'm going to turn over to you, Adam, in 1 second, but let me just clarify. And I know the answer to this question, but let's just say it for the audience. When you say subclavian, are you doing this blind or with ultrasound?
Ultrasound would be the goal. Yep, ultrasound. Yep.
And I say that because, and we'll get into it a little bit more, I think that even though the procedure has been out now for several years in many good papers, there's still some people who are like, you can't do subclavian ultrasound. It's something that we do locally, but and we'll get into it. I just want people to know that when we say subclavian is there's less infection risk, there's less clot risk, and with the safety of ultrasound, it is the ultimate line. If you don't know how to do with ultrasound, then we can get into debate if should you do it blind or IJ. What do you think, Adam?
So the first thing, anytime you're doing a triple or a central line, I always ask, did you assess all the sites? And I think that's really important. Look at both femorals, look at both IJs, look at both subclavians. Think about what the potential downstream access needs the patient's going to need. Think about how competent the proceduralist is, right? If it's an intern and it's their first central line, yeah, I want them to do a right IJ, especially if I'm not anticipating any dialysis needs. It drives me a little crazy that right IJ seems to be the preferred site for every single triple lumen in house staff. If you're going to do an IJ, let's leave the right IJ open for potential hemodialysis needs. And just go left IJ. But if it's me, it's always going to be left subclavian. Almost always left subclavian. And I would say, there's things we think about, contraindications, right? So coagulopathy, thrombocytopenia, obviously the vasculature, if it's too deep, if it's too hard to visualize, if it's collapsible, things like that. Maybe if they have a pneumothorax on the right, I'm not doing a left subclavian, right? There's things I'm contemplating, but yeah, left subclavian is my preference.
Okay. Lindsay, do you see what's happening here? This is the part where Adam starts to get hot. You feel it?
I know.
The temperature's getting a little, volume's getting up a little. This is now where we have to hone in and get him going. No, I completely agree.
Am I turning red or sweating or something? Or am I just speaking really
I think
fast?
People who've seen the show know this is the part of the show where that things are starting to get controversial.
Should we mention a femoral access point?
Yeah.
Just yet?
I don't do femoral lines. I don't. I see Mike Bonk is on, and I know he's going to argue something about data saying they're okay, but I just don't do them.
Never, or it's not your first, second, or third choice.
Yeah, maybe it's like my 15th choice. Although sometimes I will say,
How
Yeah.
many how many sites are you going for? You do an IO over a femoral?
No, of course I'll do ephemeral. And there's times where you have to do ephemeral, specifically with dialysis lines, and you just
Mhm.
have to do ephemeral. But yeah, I shy away from it pretty aggressively. And every time I see one, all I think about is how can I get it out.
Yeah. No, to your point, I the one thing that I want to highlight is that I don't think that junior proceduralists look around enough. They sort of
Mhm.
they go for whatever they sort of know, like the right IJ is the classic example, and they go there, and it's like, oh, the target that looks okay. Hey, just humor me. Let's look at the left side, and then the left IJ is like half their neck, and it's like you just didn't look, and it's
I
important to. Mhm.
Yeah, I feel the same way about actually even just ultrasound guided IVs. So
Sure.
any IV access point, I consider that you should be scanning any potential sites. So, for example, when ultrasounding, the arm, you should be looking at the entire arm and both arms. And it's really about the setup and identifying your site and only poking the patient once. So I
Mhm.
consider it a failure if you have set up, particularly because I would advocate that everything should be done essentially sterilely, and that includes our ultrasound guided IVs that will be in place for longer periods of time for things like vasopressors. And so if you're going to do that, you should do it once and you should set it up right, and that includes appropriate patient positioning, which all comes into play only after you've really identified the optimal site. And so I would agree with Adam wholeheartedly. I certainly have a preference for the ultrasound guided subclavian as well, but you really should be identifying the optimal site for any IV access point by essentially using your ultrasound appropriately and scanning the patient.
I'm like,
It's really
Lindsay,
important.
you just triggered me. You didn't even realize it. I
It doesn't
love
take
this,
much,
and this
Lindsay,
is
just so you know.
yeah, it really doesn't.
Mhm.
This comes from Paul
Mhm.
Mayo too, since you
Mhm.
mentioned him earlier. He would say every procedure has three equal parts, and I think this is just so important. It's set
Mhm.
up, the procedure, and then cleaning up. So like
Mhm.
take the time, put the ultrasound on the opposite side of the patient
Every time.
from where
Yep.
you're doing
Mhm.
it. Like for peripheral IVs, I still get a chair and I sit down and I get comfortable and just take the time, if you have it, to just get really optimize and increase your chance of success. Just like if you have the most beautiful line but you put a sloppy dressing on, or
Mhm.
you soil the field, like you have failed just as if you didn't get the line in. So like it's one of my pet peeves, and everyone who rounds with me, is when you walk down to the ER and there's just trash everywhere. Every single
Mhm.
procedure I do, I clean up after myself. Just clean up after yourself. Leave it the way you found it. Put the arms up. That's just like it's one of my things, and I feel strongly that we need to do a better job at that.
You're so gonna regret telling me that. I can't wait. I'm gonna just dump
Yeah,
trash in any
Mhm.
room that I
yeah,
see you coming down the hallway.
yeah, I'm sure you will.
You're gonna find clean blue gloves in your pockets from now.
That's right.
Yeah, there you go.
I
Wrappers, candy wrappers.
I
It's
just give a
just
shout out to Mike Bonk, who's
yeah.
referencing the 3-site study, which I will say did change my practice a little bit back more in the favor of femoral lines. Again, not my first choice, but it does make me a little bit more comfortable that if that's the line that we can get on a person, then I am more comfortable keeping that in, and people
Mhm.
can check that out on their own. We won't be going into that right now, but thanks for that, Michael Bonk. We always appreciate you. Um, let's stay focused on subclavian lines
Mhm.
because I think there's enough people that know IJs and know femorals. The subclavian ultrasound thing is something that might be a mystery to people. Before we get into the ultrasound component, let me ask you both. I know that we're probably not going to do blind subclavian, but do you train blind subclavian in the instance where you need to get subclavian access on that patient who no one else can get access on, and the ultrasound either is not available or you can't get a good window? So my question, do you ever teach blind ultrasound anymore
Blind
without
squib,
giving
yeah, I do. I do.
you
Yeah.
do?
I
Okay.
rarely do them, but like it, I don't know. I think it's important to have skill sets that account for all circumstances. So I probably, if I don't have an ultrasound, will still prefer a blind femoral over a blind subclavian just because of the risk profile.
Mhm.
But yeah. I mean, I know how to do it. I think if you know your anatomy, you should be able to do it, and it's a worthwhile skill.
Lindsay?
I think it's one of the toughest lines to teach now, knowing what we know and other preferential sites. But I personally have a deep appreciation for my own comfort, with placement, particularly because while we certainly sing the praises of ultrasound, and I would love to have an ultrasound at the bedside at all times in patients who truly need access and don't have alternative access points, there are situations where truly a blind subclavian can be life-saving. I think about patients who have major contraindications to IO access. I think about patients who are contracted, they have prostheses, they have amputations. These are patients who can't get IO access even temporarily, and in a period of extremis, you may really truly need it. And so I am very thankful for my comfort with it, and I wish I could find more opportunities to teach it, because it is sort of institutionally so discouraged. But I think it is a really life-saving skill. It just has a very narrow role, and so it makes it hard to integrate into current trainees' education.
Yeah.
Yep.
It's tough.
Very well said.
It's yeah, very well said. I agree, and it's tough. I change on a yearly basis on my stance on this. When I first started, I was doing blind subclavians, and I even used to do supraclavicular. I think it's called the Yafa approach. That was my jam. People are like, "What are you doing?" I was
That
like,
makes me a little.
I was
oof.
like, "Watch this." But it's great because you got the first rib protecting your lung, and anyway, we won't go into it. But then you start to get away from it. You say, "Well, I have ultrasound. Is this the standard of care? Should you acquire a complication on this? How would you?" What if it was your family member and you had to look at them in the eye and said, "Yeah, well, we had ultrasound, but we thought it would be important to train." Um, I'm not saying this is right or wrong. I vacillate on it. One thing that I do is I make sure that if we're going to do subclavian ultrasound, I will have the fellow or the resident keep the sheath on the needle, the plastic cover, and I go through the procedure with them. And I was like, I want you to put it where, once we walk through it, put it where you think it would be. Actually, put it up against the skin with that plastic sheath on, and then we bring the ultrasound around to see how close we are to it. It's just a little exercise. And then if there's situations, and you have to be careful about this, but if there's situations where you where a patient's crashing and it's going to take time, and you say this might be the indication to actually do an ultrasound education session. I'm sorry, do a blind subclavian session with the fellow. But it's hard.
Yeah.
If my family member had a complication, I knew there was an ultrasound, I don't know how I would feel about that. But then again, it is an important skill to have. It's one of these transitional skills that is it's kind of falling out of favor. And so do you keep teaching it, or do you focus more on doing things like IO, which we'll get into a little bit?
Yeah, I think it's going to be archaic and gone, just like the blind IJ is just not a thing anymore. I think blind subclavian eventually is going to go away. I think that ultrasounds are just so prevalent. They're got to be everywhere, especially in teaching hospitals.
Yeah. Well, let's stick to subclavian ultrasound. And for those of you who are not familiar with the technique, who wants to take it up and talk a little bit, walk us through the procedure, and then we can talk about some of the controversies, whether it be short axis or long axis. But can someone just give us a summary of the approach? Do you start out here? Do you start centrally? Who wants to take that?
Lindsay, I'm gonna ask you to do it because I've been waiting this whole week to argue with Haney about short versus long access. So I'm very excited for this moment. So I'm gonna let you go ahead and describe the procedure, so I can get ready to go.
All right,
love it. Here we go.
Well, so generally speaking, I start still mid clavicular and extending, more distally out to in the transverse position to be able to identify the subclavian vein. And, arguably, once you're getting out to, the place where you are getting best visualization, you're getting into an axillary location, just to be mindful of sort of terminology. But it is important to know that your actual, central line is then going to be terminating or kind of migrating through the subclavian vein. But I generally am just approaching it from a transverse approach at first for identification, and then trying to keep an inline, again, depending on patient anatomy and how much distance you have. And I know this is where Adam will get really excited. It depends on how much distance that you really have for visualization to be able to get your linear probe, your probe in line, and also have your needle, in a position where you can follow it with a greater degree of certainty. And the most important part, and for the safety of the procedure, is that you always need to also visualize the pleural line. And this is the part that I think gets missed a lot, is that folks are kind of focusing on the vessel visualization and not about what is the actual complication we're trying to avoid. And so making sure that you have adjusted your ultrasound such that you can identify, the actual pleural line is super important, because that angle of insertion you're going to be coming in at makes the ultrasound guided access point more dangerous in unexperienced operators' hands. And so really maintaining good visualization of both your needle tip and also the pleural line is extremely important.
I want to put this illustration up on the screen. Oh, I didn't even ask you, Lindsay. Are you doing it in? I'm sorry if I missed it. Are you doing it in plane or out of plane view?
So, I mean, ideally in plane, but that I find that with many patients' anatomy, it can become very difficult to do so. So I am happy to do it out of plane if we have to, or a short axis view. But if we can do it, longitudinally, I would love to see that the entire way in. But sometimes that may be a technical limitation.
Sure. I didn't pay her to say that, Adam, just so you know. Okay, good.
I'm teeing you up.
So if you look, and I don't have a pointer on here, I apologize. But if you look at the image on the left, what you'll see is the subclavian vein, the subclavian artery, SCV, SCA. And then, as Lindsay said, you really get an appreciation the first time you do this procedure, just how close that pleura is to the subclavian. It's not shocking to me that one of the major complications of this procedure is a pneumothorax, because it's right there. And then if you go to long axis, or the in-plane view, I should say, you'll see that you see the nice long subclavian vein right there. So these are actually the pictures that I generally see with patients, even someone who's has a big body habitus and whatever, unless they have subcutaneous emphysema. These are the pictures. You just have to take your time and work your way back. Okay, so Adam, I guess it's time to get it on. Let me know what you think.
So, yeah.
Hey, let me finish the question. I know you're excited, dude. Just calm down. Calm down. I'm going to finish this question. Now, we can recognize that we train from residency. I think we can all agree that we do the cross-sectional approach for vessel. And I think it's a higher end skill. This longitudinal approach, the ability to put the vessel in plane is a hard thing to do. And then actually to keep this tiny needle in this 2 millimeter slice of ultrasound beam, that is a skill set in itself. But the question I have for you, Adam, which I have no idea what you're going to say, is it better for someone to do this particular procedure with the pleura being so close to the vein and very dangerous to cause a pneumothorax? Do you think it's okay? I know I'm totally biasing this. Is it okay to do it in short axis or in long axis?
So here's my view. I think it's hard. Here, can you go back to that picture actually? So first off, this isn't the exact view I get. So let's look. We're looking at the left here, and so it's hard to see, but the clavicle isn't being visualized, right? So it is right there on the left side. So when I do these procedures, I start pretty lateral and I move medial with the clavicle in line. And what you'll see is that subclavian artery is going to dip below the clavicle first. And so I wait and I keep moving medial, let the artery dip below the clavicle to the point where the vein is basically partly under the clavicle, but right there at the clavicle. And so it's actually relatively easy to then feel where the clavicle is, go right next to it, and pretend in your mind that it's an IJ, right? So do the exact same procedure as an IJ, it just happens to be subclavian. Keep that pleura in line, obviously, in mind, and don't go too deep, and you can slip it right in. And there's actually, what I will do is I won't go directly in line. I will come a little bit in this scenario to the right of where it is and angle it a little bit at the same towards the clavicle. Does that make sense? I'm going farther down in the patient and aiming it up towards the clavicle. I wish I had a pointer. And so you're not even going straight down into the pleura. And I think what I would say is I'm sure you're right. In plane is probably safer and it's probably better. And I think you're also right that it's a lot harder to do. And so I try to always simplify things. Like if you notice when I approach airway, I set the patient up the same exactly almost every single time because I want to be able to walk into any scenario and just do it. And I feel kind of the same way about access is I don't want to have a different approach for an IJ versus subclavian. I want to do all of my triple lumens exactly the same, regardless of the location. And I have just found that this is how I do it. And I've had a lot of success.
I don't disagree with you. I think in your hands, doing a short axis approach is just as safe as doing it in long axis. And
that's all he needed to hear.
I know. Now we can end the show. But I'll tell you,
there's a lot of static. I can't hear you. I think we should end this show soon now.
But when you supervise a resident or even some really good fellows and you watch them with their, follow the needle tip all the way down or constant visualization of the needle tip, I have to tell you that I'm not seeing people visualize the needle tip. I see a lot of tissue deformation and a lot of bouncy, just say, oh, I see where the needle is. You have no idea where the needle is in some really good people. So if you're going to do it in the short axis, you have to demonstrate to me or whoever that you're doing that you really can keep an eye on that needle. Because again, look at that picture. Just look how close that pleural line is. If you backwall the IJ, even though we try not to backwall the IJ or the femoral vein, you're forgiven. If you do that in here, you're not forgiven. And so you really have to be like a vascular sniper to be able to get that in plane. If not, and I would make the argument that knowing that skill to be that good might be just as hard as learning how to do it in the long axis and spending the time with a vascular trainer. And I personally think, whereas I agree with your sentiment of wanting to do the same thing every time, I actually think that it's important to be ready to do multiple techniques depending on what anatomy you're presented with, because there have been people with doing IJs where they do have a long neck and I can get in a long axis, or for whatever reason I want to do an oblique view, which we won't go into. So at the end of the day, it's important for people to be comfortable with both techniques, get on a vascular simulator during your downtime and just practice in the back room with the silicone trainer just to make sure you know how to do both techniques. I definitely have my opinion on this, and I'll continue to teach in long axis unless I have somebody who's demonstrated to me that they know at every single point where that needle tip is. I just haven't worked with that many people that truly know where that needle tip is at all times, and the risk for pneumothorax for me is too great. How's that?
Let's move on.
It's pretty good.
No, I think
this is our last show, by the way. It's been great doing this with you, Adam.
Yeah, I know. This is the end of our relationship. I think great points. I've often said too that I think providers, before they can approach a central line, should show total competency in a peripheral IV. I find it a little crazy that we let them do dialysis catheters in an awake patient in the neck when they can't even put a peripheral IV in. So I think there's a lot of nuances. It scares me that they're learning two new skills at once in such a high risk scenario, that they're learning how to do it in plane and a subclavian at the same time. So I think it just depends. And yeah, let's leave it at that, because I think there's a lot of other important topics to talk about.
All right.
I've been dying to ask you this question. I'm gonna change a little bit. How about confirmation? I know we do chest X-rays all the time, right? So let's first take one scenario, and I'm gonna say this, and we're gonna move on. Is that high dose vasopressors, peripheral IV, and we put an IJ in, and we're waiting for the chest X-ray? That's always baffled me. Like, sure, get the chest X-ray, but let's move the vasopressors over immediately, because the risk of extravasation or not working in that peripheral IV is probably greater than the potential risk that this IJ is in the wrong spot. So let's say that. And the second thing I want to really ask you is, what do you think about, subcostal view, visualizing the wire during the procedure? Is that enough for you? Or do you do a bubble study, and if you see it in the right atrium quick enough, is that enough for your confirmation? What are your thoughts on that?
Let's do it. Go ahead.
I'll let you take that, Haney. I know you have a lot of thoughts about the bubble.
I do like bubbles.
Yeah.
I'm going to be honest with you. The x-ray is something I get for the hospital just to have documentation on.
Mm-hmm.
That's the only reason why I get it. And there's a couple reasons for this. The first thing is I'm always confirming my wires in the vessel before I dilate. So that to me, and I feel very good about it. I do it in short axis. I do it in long axis. I move so I see the J loop moving in plane. So I'm absolutely comfortable that I'm in the vessel because I don't want to dilate if there's any chance it's going to be in the artery. So at that moment, I'm confident that that person is in the vein. So at that point, I'm good. So I don't. The next step is that once we get the catheter in, the bubble studies are interesting. I'll be honest with you. I do it a little bit more for academics to show people. It's like, oh, this is how I know it's in there. But again, I already knew it was in there because I would not have dilated that person's vessel if there was any doubt that it's not in the vein. And the last thing, and the most understated thing is, we're using a vascular probe for this procedure. It's right there on the bed. Why more people aren't just putting the probe on the lung just to make sure you didn't cause a small pneumothorax? I've seen pneumothoraces that I've found and the x-ray has been negative. Not that I'm putting in a chest tube, but at least I know that if that patient decompensates later in the night from positive pressure, I'll know one of the biggest causes could be that pneumothorax. And so for all those reasons, I'm very comfortable saying, yep, let's hook up the vasopressors. I'm writing the order for you because I've taken much more safety in my hands of looking for it than getting a chest x-ray. And again, the chest x-ray, we're going to get it, but that's just for the chart to document that. Now, let's be fair. Are there some cases where we do all this and you see the catheter going down and then over to the side, or you see the subclavian going all the way across? Yes, that's going to happen. We can, maybe we can just touch upon whether or not we continue using those lines. But again, high dose pressors, I'm not waiting around to wait for some x-ray to come to confirm it. I'm good. Let's go. Let's start resuscitating this person.
Yeah, I was going to ask, does it matter if it's crosses midline? I mean, the subclavians that shoot up into the brain, those probably shouldn't be there.
Yeah.
But the rest doesn't matter. Or how about the ones that are too deep? What do you think about that? Like when they're all the way in the RA, I've seen people withdraw them. I usually don't. If they're not having arrhythmias and not having problems, I'm not convinced that it matters.
Yeah, Lindsay, what do you think about that? I just want to give a shout out to Sham, one of the friends of the show. Bubbles did a bubble study last night in the CQ to convert. And sometimes you do have to convince your audience around you. They're like, I don't know, you're talking all this ultrasound stuff. That's not the way we do it around here. And so that might be an indication to say to people like, look, I know what I'm talking about. I'm doing this just for you. So that's a great point, Sham. Thank you. Getting back to it, Lindsay, what do you think?
Yeah, I mean, if it was, a 4'9", patient who has a hubbed right IJ and it's curling in the RV, I'm probably going to pull that back. But if it's small, nuanced positioning and it's working appropriately and they've had no issues with it, a little bit on the deeper side is not going to cause me to, pull the line back, replace, the actual securing device and have further manipulation at a site that already is at risk for, infection. So again, it's sort of weighing, like everything we do in critical care, it's risk versus benefits, in someone who it's really very quite deep and maybe problematic because it's lying against the RV, then I'm going to pull that back. But for anything else, it might be fine right where it is.
Yeah, I agree with you. And it's one of those things where it's like, yeah, it's a little deep. We'll pull it back later, or the next team can do it. Right now we have other things to do for this patient than be paralyzed and not use this line because of a marginal indication. Adam, do we want to finish up on some IOs? I know that's always a big.
I kind of want to. I know we're after 8 o'clock, but I kind of want to finish. I think IO is such an interesting topic. So, what should we talk about? So, IOs, there's a whole lot of them. You always hear about the sternal, you hear about all these different sites. If you go to their website, they'll be like, you can put it anywhere, just drill it in. Yeah. So what there's 2 sites there's two sites I talk about using, but there's really only one site I truly use. How about you, Lindsay? What sites do you drill in?
I feel like it's the only two sites that I feel comfortable with as well, which is really, the humeral head and really the proximal tibia. And when you say really you're only really using one, it's because typically we are reserving this for, we think, cardiac arrest settings. We think about this in terms of, like peri-arrest settings. And for a variety of factors, the proximal tibia is certainly a preferred site. I say for no other reason than the ability to really safely place the line away from other operators that are doing other high risk things. And so I consider it a room safety feature to choose the site that is going to be the safest for the other operators in the room, the safest thing for folks who are, for example, doing things like chest compressions or airway management. I just much prefer the proximal tibia for a variety of factors.
But if all were equal, which one would you like? If you could have either one and it was safety and you're just allowed to have it, which one would you take?
Well, we do know that the humeral head is marginally a little higher with more rapid transfusion. So you will get circulation of your drugs a little higher, but just combining both the situational sort of the way that you have to organize your room in order to secure that proximal humeral access, and then also to maintain that line in place. So, for example, one of the major complications is the actual line itself basically bending and kinking off. It can even break in the arm. I find that happens all too commonly with things like a cardiac arrest, where the arm is sort of flailing around. And so, I will do a lot of things if I am choosing the humeral site. I will do a couple of things to make sure that line stays in place safely. And that includes typically securing the arm at the patient's side. So fully AD ducted at the patient's side once the line is in place. And then using something like a wrist restraint to then secure the wrist to usually the patient's like upper thigh. Can be really helpful. And that's sort of just a small trick of the trade that I've learned, just unfortunately from having had a lot of movement of the upper extremities during an aggressive resuscitation, which is what's required, in something like a cardiac arrest. So the humeral access is preferred as far as, how rapid, transfusions can be administered. But for a variety of logistical factors, I just really would not, I prefer not to use it.
Yeah. And honestly, the tibia is just so much easier to put in. I think for time's sake, we shouldn't go over like the actual procedure, but the tibia, it's just so easy, right? You feel the tibia plateau. It's 2 centimeters medial, 2 centimeters down. It's usually pretty easy, and you just drill in. Although I will say the IO website, it cites things like 6.3 liters per minute for the humeral and 1 liter per minute for the tibia. And you're like, ooh. And then they also talk about how quick it is from here to the heart. It's a lot different. And so like I get the physiological benefits of it. I always get confused of which one goes where, like which color goes to which one. And so I always have to remind myself that the blue one is the one I want. The blue one's for the tibia. Because like I'm always like, you're in a code and you're like paralyzed. It's the medium one that you want, right? I don't know, Hanny, what do you think about IOs? Yep. Sorry, go ahead.
Well, I was going to say, I keep it simple. I use the yellow one, the adult size one for both sites, because you can always you are always going to stop drilling as soon as you have loss of resistance. And so you can always have a longer catheter and secure it with the appropriate securing device that comes with the kit. I just find it, much like you might like to set things up very similarly, I also like to only ask for one thing. And I just, instead of getting handed the blue one when I'm trying to do the, tibial access, I just always ask for the yellow access point. Cool. And so if I could have that, I'm ready to rock.
I love what you said too, that there's no resistance, right? That's like, I'm sorry, Hannah, I keep jumping in. That's like the number one thing people like push down. It's self-drilling. You actually just kind of put it on the skin, break the skin, pull the trigger, and it's going to go. When it hits marrow, it's going to stop going. So you don't need to push. It'll self-drill into the correct spot.
Yeah, I mean, I give a little bit of give, but once you know once you get through cortex, I mean, anyone that's done enough of these, you just have that give, and that's enough. And then there's a long way before you go through the other end. Although that being said, I've seen people go through the other
Yes.
end. I think it's just the adrenaline in the moment. So get through the skin, put a little bit of pressure, and then once you feel your first give, you're good. And I agree with Lindsay. Just ask for the yellow, keep it simple. You can always, when you keep it out, you can always put 4x4 bolsters
Mhm.
on all sides to keep it elevated so someone doesn't come by and kind of push it deeper and cause that. But that's my go-to. And then some people, you're just restricted. Even if you want to use the blue, their body habitus is such that you have to use the yellow just to get through the amount of subcutaneous tissue. In terms of placement, uh, if we're talking about doing the humeral, that's when I want to get a lot of volume in there. So if I have somebody who's a trauma patient, I might go for that side first. If I have somebody who's pregnant or has any intra-abdominal bleeding, because theoretically I could be losing blood volume from the tibia and the pelvic veins where they're feeding into, there could be extravasation of that product. I want to come centrally. I'll try to stay, in the humeral. But if it's a cardiac arrest that's straight up, again, there will be people say theoretically you're closer to the heart, that epi's getting
Mhm.
closer. Yes, okay, but there's enough evidence that says that I don't know what just happened there. That was whoa. Okay, I want to emphasize my point, but I think a tibia is just fine. And the other thing is that you're just out of the way. There are people doing
Mhm.
stuff at the head of the bed. They're doing CPR. They're doing airway. They might, whatever. I'm out of the way down there, and I put 2 in. And since this is what gets me hot and excited, I see too many people trying to do central lines during a code.
Mm-hmm.
And
Mm.
we have to acknowledge that there's you can put anything you want through an IO. You might not be able to hook it up to a Belmont type system or a rapid infusion of products, but you can put anything you want, any vasopressor, any drug, and the amount of needle sticks that I've personally seen during codes, the amount of time it takes to do a central line, the amount of failed attempts where people are just kind of screwing around in the groin and looking with ultrasound, and
Mhm.
it's like, what are you trying to do? You want good vascular access? Put an IO in and just be done with it, and then move your resources to the other more important things in resuscitations. We're lucky we work in an academic center, and there's usually 70 people in the room to do different tasks. But in the community, where you might only have one doc and one nurse, like, the ability to put something in that's quick and reliable and then move on to a different task is vastly understated with using IOs. So that's my 2 cents on it. For me, the only stick that I need to do, like true vascular access, is an A line, and we won't go into that now. That might be a talk for a different episode. But for me, that's
Mhm.
the only vascular access, true vascular access, I'm placing during a code.
Yeah, I agree. I jumped to the IO very fast, and I think it's underutilized. And I don't want people to go start putting IOs in everyone, but during a code situation, I don't even
Mhm.
mess around. Like, you'll see people like trying to get peripheral IVs. If they're pericode or they're coding and I need access, I just put the tibia IO in. I don't
Mhm.
even think about it. Um, Obviously, think about, if there's overlying infection or if there's a fracture, if there's a prosthesis, like the normal contraindications you have to know. But for the most
Mhm.
part, they're very easy and very quick to do.
Right. Yeah, definitely have to know the contraindications to doing it, but all else being equal, it's a great line.
Mhm.
Man, we are over, but it was, I mean, I don't care. It was a great discussion, and the comments were in. We had a lot of viewers tonight. Lindsay, any closing thoughts?
No, thanks for having me, Haney. And this has been a treat. I like to tease Adam as well and get him fired up about things that are
It's
that
frankly the
are
best part of the
exciting
show.
about. It is. It is. So I appreciate the opportunity. It's always a good day to talk about IV access.
Awesome. Will you make us a promise and come back again on a later
Be
show?
happy to.
Awesome,
Yeah,
Lindsay. All right. Well, be safe, and we will see you in the unit.
sounds great. Thanks.
Adam, I knew that
Hey,
was going to be
Nate.
a great show, and it did not disappoint.
Yeah, I learned something tonight. I learned that my value is to be the punching bag. I thought after 25 episodes, I thought I brought something to the table, but really it's just to make fun of me.
What do
But
they
I'm
say?
okay with that. I'm
What do
okay
they
with
say?
that.
Punch up? You should not punch up, or you should not punch down. What's the wrong one to do? You should punch up?
Punch down. You
You
can't
should
punch
not
down.
punch down.
Yeah, yeah.
No, I wasn't punching down. I was punching up.
All right.
I
There you go.
respect you
There you go.
immensely. So I
Yeah.
would.
Yeah.
It's only coming from a good place. Just know that.
That's right.
So lots of great comments tonight. I'm sure what we're going to do is I think for this episode in particular, we're going to monitor the comments for the next couple days to weeks. I know there's going to be a lot more discussions. People are probably going to be asking for references, and that's okay. We're happy to provide them. So please drop the comments for the video if you're watching live or if you're watching this on replay. Ask us some more questions. We're going to be monitoring it. And don't forget to like and subscribe to the channel. We didn't say that enough this episode, Adam.
Yeah. No, this is the first time we said it. Yeah, I specifically the question about central versus peripheral A lines, like that deserves some attention.
Yeah.
And so we'll add that maybe to our cardiac arrest A line topic.
Oh, yeah.
Maybe you and I should do a little quick one on that. That'd be fun.
We should do a cardiac arrest episode, like how to run a code like a boss, or like
there
a
you
green.
Go. There you go.
I did promise people that I would do a giveaway, and I feel bad because you know what we'll do? We're going to do this. We're going to do a random giveaway for people who leave something in the comments, and we'll run this for a week. So leave in the comments. What should we do? What's a question to see that people are paying attention and watch the entire episode? What would be a question to ask? And I'll take care of the prize. What do you think, Adam?
Oh, wow. That's the hard part. What should we ask? How about something simple? Just like what is the name of the law discussed about flow dynamics? I think that is a simple question that if you were watching, you would know.
Perfect. So throw that in the comments.
Hopefully someone answers.
And I'm going to pick 3 random people. I mean, if one person gets it, one person gets it. But we're going to do this for about a week. And then, you know what we'll do, Adam? Here's what we'll do. We're going to do it till the next Critical Care Lounge. I'm just shooting off the hip right here, but these are all amazing thoughts coming out of my head. We're going to run the contest till the next Critical Care Lounge. And then on the show, we'll announce the 3 winners and the prize, which is going to be a free access to the ResusX conference, the digital version. So you get free access to that for 3 people. Wow. So remember, what is the name of the law that we discussed with regard to fluid dynamics that was mentioned in the show? So drop it in the comments, and we're only going to give you the prize if you subscribe. So there's that too. Adam, what are we talking about next time? Did we even come up with something, or we're just going to get back?
No, that's we got to do that. We got to figure out when and what, but we will be we'll let everyone know.
How about this? The next talk we're going to do is going to be cardiac arrest like a boss.
There you go.
That's the next episode, and we'll give you more details soon. And we're back on track for 2023, so we're hoping to come at you every 2 weeks or so. So stay tuned. We'll be announcing that soon. Resuscitation like a boss. And Adam, it was always good to hang out with you, and I'm excited for 2023. This is going to be Lounge's year. All right, brother.
All right.
Good.
Take care, everyone.
Bye.